Hi, very good morning. I'm Dr. Janak Patel, MD physician. Today we'll be talking on one of the another topic in cardiology, that is atherosclerosis, which you will see in your everyday practice. And secondary to atherosclerosis, you come across the most common disorders, that is hypertension and ischemic heart disease, peripheral arterial disease. So this will be a very important topic which you will see very frequently in your everyday practice. We'll be discussing under the common heading definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, and treatment part. By definition, atherosclerosis is also called arteriosclerotic vascular disease, or short form we call as ASVD, arteriosclerotic vascular disease. A stands for arterio, S stands for sclerotic, V stands for vascular, D is for disease. So whenever you say atherosclerosis, means it is involvement of the artery by deposition of lipid material below intima. While arteriosclerosis is involvement of artery by any etiology, but the most common etiology is atherosclerosis. It can be involvement by SLE, that is systemic lupus erythematosus, or periarteritis nodosa, or senile changes, or you can have involvement because of TAO, or we call Berger's disease, that is thromboangiitis obliterans. And one of the most common disease you will face in your everyday practice is diabetes mellitus. So we have got a different terms called arteriosclerosis, arteriolosclerosis. When we say arteriosclerosis, it is atherosclerosis, which is involvement of the medium size to large size artery, and the commonest cause of that is atherosclerosis, while arteriolosclerosis is hardening or of small size artery. Atherosclerosis is because of the atheromatous plaque. Atherogenic substances are the substances or the process which causes atherosclerosis, and development process of atheromatous plaque is called atherogenesis, and atheroma is accumulation of intracellular or extracellular lipids in intima, below the intima, in large size and medium size artery. We know the commonest etiology for atherosclerosis. We can divide into two big groups: modifiable, or another word for modifiable is controllable, and second we call non-modifiable or uncontrollable. In non-modifiable group, advanced age, male are more prone as compared to female, genetic history, family history of premature coronary heart disease, certain race population, or we use the word hereditary. Among modifiable cause, the most common cause is dyslipidemia, or we call hyperlipidemia, where you get an abnormal elevation of a total cholesterol. You have got a raised level of LDL, or we call as a low density lipoproteins, low level of HDL, or we call high density lipoproteins, raised elevated level of triglyceride we call as a hypertriglyceridemia, or abnormally high level of apolipoproteins. These are all included in dyslipidemia. The other modifiable causes are smoking, alcohol, uncontrolled hypertension, diabetes mellitus, obesity, and if the person who has got hypertension, diabetes and obesity together, it fits with cardiometabolic syndrome, or we call syndrome X. The commonest causes of dyslipidemia we'll be discussing more in detail in a chapter of hyperlipidemia. Dietary factors. You can have other modifiable conditions like thrombogenic factors, endothelial dysfunction, sedentary lifestyle, lack of exercise, mental stress, anxiety, anger, infection like chlamydia or herpes, homocysteine level if they are abnormal. You got an inflammatory marker like CRP or highly specific CRP, HSCRP, even vitamin D deficiency. There are many more factors which are included in a risk factors, but we are trying to cover up some of the most common. So these are the common conditions. As far as hyperlipidemia is concerned, the commonest etiology is familial, or we call genetic, which accounts for 5%, and 95% of the time it is because of abnormal high fat diet, type 2 diabetes mellitus, obesity, cardiometabolic syndrome, chronic alcoholism, the person who are on beta blockers, hydrochlorothiazides, nephrotic syndrome, chronic liver disease, oral contraceptive pills, particularly in liver disease, obstructive jaundice or cholestasis, hypothyroidism. By and large, we have already mentioned they will have a high level of cholesterol, high level of TG, LDL level will be elevated, and there will be low level of HDL. It may be associated with abnormal high level of apolipoproteins. These are all the risk factors which are being there, which are included in hyperlipidemia or dyslipidemia. Primary, or we call familial or genetic, it accounts for 5%, and all right from 2 till 11, they are all secondary, and secondary accounts for 95% of the groups. So these are all the abnormal risk factors: diet, sedentary lifestyle, anxiety, stress, old age person, obesity, even pregnancy. This is another way of explaining sedentary lifestyle, abnormally high fat diet, anxiety, stress, anger, smoking, uncontrolled hypertension, diabetes mellitus, obesity, all those. This we'll be discussing in detail in a chapter of hyperlipidemia. That is, these are the optimum level, these are the borderline high risk, these are high risk group, and these are very high risk group. This is total cholesterol, LDL, HDL, and triglyceride. And when you divide triglyceride by 5, you get VLDL. There are other factors which damages the intima and predisposes to atherosclerosis and formation of a thrombus. So atherosclerosis can be enhanced by bacterial infections like chlamydia or herpes, uncontrolled hypertension, high level of homocysteine, smoking, diabetes mellitus. All this can initiate endothelial dysfunction and can end up into atherosclerosis enhancement. H. pylori and chlamydia is the most common infections. As far as pathophysiology of atherosclerosis is concerned, whenever there is an elevated level of lipids, these lipids will be oxidized and they will be taken up by what we call as a macrophages. So macrophages will pick up this and will result into mainly LDL is oxidized and that will be converted into what we call as a fatty streaks. And these cells, macrophage cells which are rich in lipids, they are called foam cells. And when foam cells get together, it will give rise to formation of what we call as a plaque or we call as a fatty streaks. This fatty streaks is surrounded by a thin capsule, and depending upon the size of the plaque and the capsule, it is called vulnerable plaque or stable plaque. And this decreases the lumen size of artery, and because the lumen is decreased, the blood flow decreases, and so there is a decreased blood supply to the distal part of that particular artery which is being involved. So it can end up with involvement of the cerebral blood vessels, renal blood vessels, peripheral arteries, retinal blood vessels, etc., coronary artery, etc. So it can involve coronary artery, cerebral blood vessels, renal blood vessels, retinal blood vessels, as well as peripheral artery. Now, if there is a thinning of the capsule of a plaque, it becomes vulnerable and it can rupture, secondary due to stress infections like chlamydia or H. herpes simplex. And once the plaque ruptures, the endothelial surface is exposed. It will give rise to exposure of collagen tissue. There will be activation of the intrinsic factor. Platelet will be attracted. You will get a primary platelet plaque formation, secondary platelet plaque formation. There will be activation of the coagulative cascades, and there will be formation of a fibrin. Fibrin monomer will be converted into fibrin polymer, and it will give rise to formation of a mesh in which RBC will be trapped along with platelet, and it will give rise to formation of what we call as a clot. Because of formation of a clot, now further lumen will be occluded and you will have a occlusion. It may be partial occlusion or it may be complete occlusion. When there is a complete occlusion, there is a lack of blood supply to the distal part, lack of nutrition, lack of oxygen supply. Secondary to lack of oxygen supply, you will have anaerobic metabolism. Secondary to anaerobic metabolism, you will have a decreased energy production. So extremity will be cold, clammy. Because of anaerobic metabolism, lactic acid production. Secondary to lactic acid production, a person will start complaining of pain, cramps, leg cramps, we call claudication. And if it is totally occluded, now you will start getting necrosis of the tissue and there will be shrinkage. This we call as a dry gangrene, and there will be clear-cut line of demarcation. So this will be the thing what can happen in this atherosclerosis. Now secondary to atherosclerosis, also there is a damage to what we call as media layer. Damage to media layer will give rise to thinning replaced by fibrous tissue. You will have a weakness of the arterial wall. There will be decrease in elasticity, and that will slowly give rise to formation of aneurysm, abnormal distension of an arterial wall. This aneurysm can give rise to multiple complications. We have already discussed in aortic aneurysm that it can rupture, you can have dissection, you can have a formation of calcification, you can have formation of a thrombus and thromboembolic phenomena, and the artery which are arising from the aneurysm or after the aneurysm, you will have a diminished blood flow. So pulse volume will be less, blood pressure will be less, diminished blood supply to the artery which is distal to or arising from aneurysmal part. There will be radiofemoral delay, or there may be radioradial delay depending upon the site of aneurysm, etc. So this is the entire pathophysiology of atherosclerosis. This is a slide which is showing you how exactly the lipids are being absorbed from GI tract, which is delivered to liver, and from liver, this is from GI tract, you get absorption, and then chylomicrons will be converted into remnants, which will be finally converted by liver into LDL, will be converted into LDL, and then that will be further picked up, and you will have a conversion that into HDL. So this is a cycle which is going on in the liver and outside the liver. This is in capillaries, this is in capillary. You will have a remnant formation of what we call as a very low density lipoprotein. These are remnant of chylomicrons. These are VLDL, which is thrown by liver, which will be converted into intermediate. Low density lipoprotein will be converted into intermediate, then intermediate will be converted into LDL, and you will have also formation of HDL, and that all will be picked up by liver again. This is that entire cycle. From intestine, chylomicron will be converted to remnant, goes to liver, it is converted into VLDL, that VLDL comes back again into bloodstream, it will be converted into ILD, intermediate density lipoprotein, which can be converted into LDL, which will be again picked up by liver. Also, this intermediate dense lipoprotein will be converted into HDL, or we call as a high density lipoprotein. Also, you will have a formation of LDL into HDL, and this HDL will help to remove cholesterol from a fatty streaks, and if HDL is high, you can have a reversal of atherosclerosis. This slide will be showing you again in a chapter of what we call as a hyperlipidemia, which I have discussed before. Will be still taking another lecture for you for the 4th year student. So VLDL, IDL, LDL and lipoprotein A, these are all atherogenic, while HDL is a good cholesterol which removes cholesterol from peripheral tissue. And I already explained you that secondary to atherosclerosis, you have got endothelial dysfunction and injury, which will give rise to adhesion of platelets and monocytes. There will be release factor. There will be smooth muscle proliferation, recruitment of T cells, and you will have a formation of an atheroma. And this atheroma will have a capsule surrounding that fatty material, which we call as capsule. Depending upon the size of the capsule, thickness, we call as a stable plaque or unstable plaque. Because of the damage to endothelium, there is a platelet adhesions, there is a release of platelet factors from platelet, which we call as a primary platelet plug and secondary platelet plug. You will have a proliferation of myointimal cells. There will be formation of collagen tissue. Damage to endothelium will give rise to migration of monocytes into intima, which will be having increased level of lipids we call as a foam cells, and these foam cells will give rise to formation of what we call as a proliferation of myointimal cells and collagen synthesis. There will be diffusion of a plasma protein into intima, oxidation of LDL, and that will be picked up by these monocytes, giving rise to foam cells formation, and this entire process gives rise to what we call as a atheromatous plaque. Hypertension also accelerates the damage to the endothelium. Hemodynamic stress also damage to endothelium. High level of LDL also will give rise to endothelial dysfunction, and toxins from cigarette smoking, alcohol, bacterial infection, etc. can also have an endothelial dysfunction. So this will be the entire pathophysiology of atherosclerosis. So secondary to formation of atherosclerotic plaque, there is a remodeling of a arterial wall. Atheroma will give rise to a complication, destabilization, or we call as a plaque rupture. And secondary to rupture, plaque hemorrhage and thrombus formation we call as a thrombosis, which can end up with embolism and can give rise to an acute occlusion of a small blood vessels. This plaque can enlarge and can go into complications, or it can occlude the lumen, giving rise to ischemic episodes. That complicated plaque can regress back if lipids are controlled very nicely. You can have stabilization of the plaque and regression of the plaque. If treatment is not given, it can destabilize and it can give rise to complications. Secondary to lumen stenosis, you will have a decreased blood supply to the organ and ischemic changes. So fatty streak formation, lipid rich plaque formation, and there will be lipid core, and there will be a fibrous capsule. If fibrous capsule ruptures, it gives rise to exposure of collagen tissue to the blood, and that will give rise to formation of a thrombus, and this will decrease the lumen size further. Depending upon the size of the thrombus formation, you can have a partial occlusion or a complete occlusion. So right from stage 1, there is a monocyte adhesions we call migration, which will pick up lipids. So lipid containing macrophages we call as a foam cells. So there will be deposition of foam cells. These foam cells will be deposited below the intima, or we call in intima. Then there will be appearance of an extracellular lipids. So these lipids will be coming out from cellular material to the extracellular space, and that we call as a fatty streaks. Then you have got a core formation. So we call as plaque formation. Then this fibrous plaque can be stable or unstable. Unstable plaque will rupture and give rise to thrombosis. And this is what happens. This is on one side what are the changes which is happening in intima, and these are the effects: early onset and clinical correlations depending upon what damage you come across. Very simplified form it is explained. This is normal. Then you get a formation of a foam cells, fatty streaks, intermediate lesion, atheromatous plaque formation, fibrous plaque. Plaque gets thinned out and rupture and gives rise to formation of a clot. This will take a very long time, but once this happens, you will start having symptoms and signs, or we call complications because of atherosclerosis. So this will be all the complication once the plaque ruptures. Unstable angina, myocardial infarction, acute coronary syndrome, and person can have sudden cardiac death also. If cerebral blood vessels, stroke, and in a peripheral artery, critical leg syndromes or critical leg ischemia. So this will be all the thing. Before that, because of peripheral artery, you can have claudication, and in case of an coronary artery, you can have stable angina, or we call angina pectoris. But right from normal till occlusive symptom starts, person can be asymptomatic, but it will take a very long period. You can see that it will take 10 to 30 years before you start getting symptoms. So rupture, ulceration, erosions, hemorrhage, you will have a thrombus formation and atheroembolism, damage to media, aneurysm formations, but it will require decades to become significant. And acute plaque changes can have rupture, thrombus formation, hematoma, and can produce acute clinical sequelae. These are all the stages which we have already shown you before. When you get a fibrofatty plaque formation, there is a occlusion, but it is not significant enough to produce symptoms. But when you get vulnerable plaque, chances of endothelial dysfunction, rupture, and clot formation, so that can happen, and that will start producing symptoms, and that will be acute symptoms. And it can also give rise to critical stenosis, or it can be occlusion, acute occlusion, and necrosis because of thrombus formation, or you can have an aneurysm formation and rupture of aneurysm and complications secondary to aneurysms. So this is stable plaque, this is unstable plaque where there is a thin lipid core, and secondary to inflammation or infections or risk factors like stress, etc. You can have a rupture of vulnerable plaque, and that will end up with thrombus formation, occlusion, and thrombus formation, and that can give rise to acute coronary syndrome. If you get dislodgement of an embolus from a thrombus formation, it can block the artery, but because of a collaterals, you do not get symptoms of ischemia. But if it blocks the artery where there is no collaterals, you will have a ischemia followed by an infarct if the collateral does not develop or does not open up. So you will have a two type of consequences. In spite of an microemboli, still person do not have any because of good collaterals. So person may not have any symptoms and signs. So these are all the different stages of atherosclerosis, and these are the symptoms which can develop depending upon at what stage you pick up the person. Usually we use some of the terminology depending upon the site. We call coronary atherosclerosis, carotid artery, peripheral artery, renal artery, retinal, size wise, big size, medium size, small size artery, and depending upon the damage, sorry, this spelling is wrong, thrombosis, it should be thrombosis, this should be O, thrombosis, thromboembolism, occlusion, peripheral artery involvement, aneurysm formations, and then complications secondary due to aneurysms. Clinical picture will also depends on this. Will not be discussing in detail. This will be the early finding in atherosclerosis, where you have got deposition of a fatty material we call tuberous xanthoma, which are flat, yellow and firm. When it is deposited in the eyelids, this eyelids etc., these are called xanthelasma, which are usually small, multiple, longitudinal, creamy orange and slightly elevated papules, mainly on the eyelids. These are deposition at the knuckles. They are large size. They are called xanthomata tuberosa. They are mainly seen on the knuckles. When it is seen in the skin, multiple small eruption types, they are called eruptive xanthoma. And these are usually secondary due to severe hypertriglyceridemia. This is classical xanthelasma. Hello. Hello. હા હા બસ ફાઇન બેટા હું અત્યારે લેક્ચર કરું છું તું મમ્મીના ફોન ઉપર કર મમ્મીના ફોન ઉપર કર હા So these are called xanthelasma. This is xanthelasma tuberosa. So these are different slides showing you tendinous xanthoma. You can see these are eruptive xanthomas. This is a slide which is showing you all complications which can happen secondary due to atherosclerosis. When cerebral arteries are involved, stroke, TIA. If you get arch of aorta involvement, you can have aneurysms. Coronary artery can give rise to angina, MI, acute coronary syndromes. Because of renal artery, etc., you can have a renal hypertension, peripheral artery, peripheral arterial disease, etc. This slide already we have shown you before. So these are all the complications which can happen secondary due to, we always say, brain, eye, kidney and heart. These are the four main target organ, and we include even peripheral artery we call as a peripheral vascular disease. These are all the complications which can happen secondary due to atherosclerosis. This diagram shows you involvement of coronary artery leading to acute myocardial infarctions. So investigation will depend upon, the main important is history, physical examination, and you try to find out modifiable causes and non-modifiable risk factors. For that purpose, lipid levels, GTT, or sugar fasting PP, HbA1c and random blood sugar to find out the effect on the target organ as far as cardiovascular system is concerned, ECG, echo, chest X-ray, if required, TMT, treadmill stress testing, angiography, or you can combine angio with MRI or CT, and you can also go for calcium score. As far as eye is concerned, fundoscopy, CNS, you can have carotid intima media thickness, pulse wave velocity, CT MRI or CT angio or MRI angio, in kidney, blood urea, serum creatinine in urine, abdominal ultrasound, peripheral vascular disease, you can go for ABI index, Doppler, or if required MR or CT angio, or you can have a duplex Doppler ultrasound. All these are investigations which can help you to identify. These are the for risk factors and these are for effect on the target organs. Even before the person starts developing a complication secondary to atherosclerosis, these are the risk factors estimation and these are the other tests like carotid intima media thickness by ultrasound, then MRI for finding out the carotid plaques, aortic plaque, can coronary calcium score by CT, ABI index, brachial vasoreactive measurements by ultrasound. You can go for vascular compliance by measuring the radial tonometry, or you can go for a fingertip radiotonometry, etc. There are many newer investigations which has come up. Depending upon that, you can go for to find out early detection of atherosclerosis. So these are some of the things which can help you, like coronary artery calcium score, ABI, CIMT, that is carotid intima media thickness by intravascular ultrasound, pulse wave velocity, etc. So by and large, non-invasive methods like ECG, echo, PET scan, carotid calcium score, coronary artery calcium score by cardiocity, pulse wave velocity, etc. By and large, the invasive technique like intravascular ultrasounds, those are not preferred, and for coronary artery, you can go for CT angio or MRI angio. Differential diagnosis, usually atherosclerosis does not require any differential diagnosis. Management part, prevention is better. So for prevention, rigid control of risk factors, which includes diet, we call as total lifestyle modification, low fat, high fiber diet, regular exercise, stop alcohol, stop smoking, maintain optimum weight, we call loss of weight by a good diet control and exercise, reduce mental stress. If person is diabetic and hypertensive, rigid control of diabetes and hypertension. And if person has got hyperlipidemia, control of dyslipidemia by using statin or fenofibrates. If there is already atherosclerotic plaque formation, then antiplatelets. If there is unstable plaque, anticoagulants. And if there is already occlusion by thrombus, thrombolysis. And in spite of this, if still there is a chance of complication, endovascular treatments, or we call revascularization. So control of risk factors, all blood pressure, diabetes, obesity, stop smoking, stop alcohol, control of dyslipidemia, regular exercise, etc. Say bye-bye to angina. You have to avoid all this: smoking, diet control, sedentary lifestyle, alcohol, etc. should be avoided. So preventive measure for this we call primary prevention. Once the damage has taken place, we call secondary prevention. And after that, if you do anything after the damage to the target organs, then we call as a tertiary. So try to have those. Primary prevention is always better, or we call primordial prevention. So get regular checkup, rigid control of blood pressure, control of lipids, don't smoke, exercise regularly, healthy weight, eat healthy diet, manage stress, and rigid control of diabetes. All these are absolutely necessary. And these are included in primary prevention. For endovascular treatment, there is one thing called as a revascularization. In revascularization, the most important part which is utilized is thrombolysis. By using thrombolytic drugs, it can be added by mechanical, we call as a percutaneous coronary intervention, PCI, where you get angioplasty, that is balloon dilatation, followed by a stent, or you can go for a surgical intervention called CABG, coronary artery bypass graft, or you can have a combination of the two, we call as a hybrid. For treatment of artery, atherectomy means you remove the atheromatous plaque by rotablade, and arterectomy, you remove the atheromatous plaque with a clot. You can use stent, balloon angioplasty, bypass graft, etc. In the person who has got a very high chance of what we call as a thromboembolism to cerebral blood vessel, you can use stent with a net, and that is put usually in a carotid artery. So these are all the different procedures you can go for. This is CABG which is being done. These are grafting which is done for a peripheral artery. In rare cases, you may require a lipid apheresis where there is a severe hyperlipidemia. They are also trying use of HDL to decrease the amount of atherosclerosis, but still it is not successful. They are going for immunotherapeutic approach like lipid-based vaccines, not successful. So vaccination is still not successful. Immunization with peptides of ApoB100 is again not successful. Heat shock proteins are utilized, etc. As far as complications of atherosclerosis is concerned, the most common which we face in everyday practice is hypertension, which we label as primary. And if you got only systolic being elevated, we call as isolated systolic hypertension. As a complication of atherosclerosis, you come across plaque rupture, thrombus formation, thromboembolism. Partial occlusion gives rise to ischemic episodes, and total occlusion will give rise to infarcts. Depending upon the site, you can have a CNS complication, cardiovascular complications, peripheral vascular disease, retinal, and kidney. And damage to the blood vessels, you can have an aneurysm formation which can have a pressure effect, thrombus formation, thromboembolism, rupture, and dissections. So this is a list of all different complications. To summarize, cardiovascular, you can have hypertension, LVH, ischemic heart disease, heart failure, acute MI. In kidney, AKI, CKD, peripheral blood vessels, claudications to gangrene, dry gangrene in retina, hypertensive retinopathy, and as far as CNS is concerned, TIA strokes. This is compiled picture. So thanks for taking out time. I know your time is valuable and I appreciate your spending time with me. Thank you again. So we'll see you again in the next lecture. Hope this will be very helpful to you.